Afternoon, everyone. Thank you for joining us for the virtual Lunch and Learn for One CME. I am your host, Susan Bray, the East Valley Dignity Health Transfer Navigator. Today we have Dr. Rachel Bond with us. Dr. Bond is a board-certified cardiologist. She's focused on women's heart health, and she's authored several articles referencing sex and gender differences and cardiovascular conditions that predominantly affect women, along with opinion pieces aimed at addressing health equity, reducing health disparities, and promoting the professional development of women and minorities in the health science profession. Today, Dr. Bond will be sharing some of that content with us and how it relates to our everyday practice. But first, we'll go over a few housekeeping items to make sure everyone is able to claim their CME following the discussion. Please click on, if you've joined us by WebEx, by the computer, please click on your screen and click the chat bubble that should appear at the bottom of your screen. As you hover over it with your mouse, then we've already sent out instructions on how to claim your CME. Put your email in the chat. We'll send you an email with instructions to claim it. Will include a survey, which is required in the CMA world to claim your credit. If you're interested in future virtual CME so that you can claim an email, receive an email invite and a WebEx link, this is how we'll return the CME to you by email. If you're calling in, please text me at 928-699-4797, or you can email me at susan.bray, and that's B for boy, R-A-Y, at dignityhealth.org to get the instructions emailed your way or texted your way. We'll again have this information at the end of the presentation in case you missed it, and we'll also give you some time to ask questions. You're welcome to type questions into the chat area. We'll answer them at the end of the presentation. We'll also take verbal questions by phone by Dr. Bond as well at the end of the presentation. So with all of that wrapped up, let's get to the good stuff. I present to you Dr. Rachel Bond. Thank you.
Thank you so much, Susan. So thank you all for coming in today and signing in, I should say. We're going to have a very wonderful talk about a few interesting topics relating to women's heart health, particularly focusing on acute coronary syndrome. So as the title entails, it's really going to be focusing on the spectrum of acute coronary events in women. Just for myself, I am the medical director of the Women's Heart Health Program here at Dignity Health, which I will be highlighting in a little bit after the talk. I have no faculty disclosures at all. So to begin, just for an outline, we're going to be discussing the background, really the importance of having a Women's Heart Health series. Why is a series, a three-part series, is so pivotal? We're then going to be focusing on the spectrum of acute coronary syndrome pertaining to women in particular. We're then going to be reviewing gender disparities of guideline-directed therapy specific to acute coronary syndrome. And then lastly, we're going to be addressing steps for improvement on how to improve these disparities that we see nationally. So to begin, I'm going to be focusing on background. So I like to always begin majority of my talks with a history lesson. So even the ancient Greeks knew that there was a difference between women and men, so much so that they assigned a goddess of women's health, that goddess being Hygeia. She is the daughter of Asclepius, who's the god of medicine, who you can see here in this very famous sculpture where she's depicted handing her father the snake that wraps around the staff, which is a symbol of medicine. And when we think about heart disease in women, we have to realize that women have different pathophysiology and different anatomy when it comes to the heart particularly. However, unfortunately, although the ancient Greeks understood this difference, us in America, we haven't had the opportunity to really do such a good job at understanding this difference. So in one attempt to do this, which in my opinion was unfortunately not a very well thought out attempt, there was a conference in the 1960s. It was the first conference that was really focusing on women and heart disease. But when you look at the title of the conference, it's Hearts and Husbands. The objective was not to focus on heart disease in women, but were for women to learn how to keep their husbands' hearts healthy. The conference, however, was only open to women. Actually, they had a very good turnout of about 10,000 women who attended to hear Dr. Paul Dudley White explain again the important role of the wife in protecting her husband's heart by helping him take advantage of the current knowledge of controllable factors that can help reduce the risk of heart attacks. And although this conference really was aimed at inviting women to the table, unfortunately, it didn't provide them the information that they needed to understand that heart disease affects them just as much. Fast forward a few decades to the 1990s, and if you even look at the title of Reader's Digest, you'll see, "Is Your Husband Headed for a Heart Attack?" Again, having the misconception that heart disease does not affect women, it's only a male's disease. And even in the medical field, I can remember in medical school learning about this myself. If we all, as clinicians on the call today, could remember utilizing netters during our anatomy class, when I was learning about coronary artery disease, the depiction I saw was it's a male disease, where we see here, sorry, laser pointer, we see a male clutching his chest, probably a older elderly male, male being elderly white male leaving a restaurant, clutching his chest. And this is really the depiction as a clinician of what we thought was somebody who's the face of heart disease. Even in the media, these are the larger faces that we think about, but we know that this doesn't just discriminate against women. It actually is an equal opportunity disease. And even our most famous princesses can have heart disease as well and succumb to it. So that leads us to really what the scope of the problem today is. And that problem is that 47.8 million women in the United States are affected by heart disease today. Why? Because it's the #1 cause of death among women. And to put that into perspective, when we think about heart disease, we know that 1 in every 3 deaths each year account for heart disease. When we compare that to breast cancer, which the vast majority of both patients and clinicians think is a woman's #1 cause, we see that that's actually 1 in 31 deaths. And what that translates to for heart disease is that about 1 person dies, particularly 1 female person dies from heart disease every 80 seconds. And one reason that may be is that 90% of women have 1 or more risk factor for heart disease. And I'm going to delve into very briefly what these risk factors are, because again, the real focus of our talk is focusing in on the spectrum of acute coronary syndrome. But I also wanted to focus on the fact that 80% of the time, heart disease is a preventable condition. And that's astounding because we have ways of changing this if we get to these patients early. Now, this graph I always like to reference because I think it paints the picture very well. And what we can see in this graph is really beginning before the 1980s, men in blue, women in red, were dying at a much larger rate from heart disease compared to their female counterparts. And what we then began to see really in the mid-1980s, 1984 to be exact, women actually were dying at much higher rates than their male counterparts. And we saw a steady decline in the number of deaths from cardiovascular disease in males. Well, what happened in the 1980s? We had innovative technologies such as balloon angioplasty. We also had the advent of statin use. And unfortunately, all of those treatments were being disproportionately used on men and not on women. And with that, we saw a rise in the number of deaths from heart disease in women. And it really wasn't until the year 2000. And in 2000, really a pivotal trial came into play in the late 90s, which was the Women's Health Initiative. And what the Women's Health Initiative not only depicted, which was that hormone replacement therapy may not be ideal for the reduction of heart disease in women. If anything, it may increase the risk based on that particular study. What that study really highlighted was we needed more sex-specific research. And with that, the American Heart Association created the Go Red for Women campaign. They then began to join with the American College of Cardiology and really come up with these sex-specific guidelines. So we then began to see a steady decline in the number of deaths of heart disease in women. Unfortunately, in the most recent years, we're seeing that there's a trend in the wrong direction. And one thing I'd like to say is that where is that trend really being focused in on? Because in all honesty, we've been doing a really good job in managing heart disease, but it's really based on one's particular age as well as one's particular gender. And I say that because when we separate our patients by age as well as gender, we see that heart disease deaths have declined steadily over the past 3 decades for those above the age of 65. However, for those less than 55, particularly women, we can see that that's actually not the case. Here, less than 55, it's pretty flatlined. Additionally, even 55 to 64, but we don't see that there is that steady decline. And it really raises the question, well, why are young women, and it's actually particularly women of color, at the greatest risk for heart disease? Why are they dying from cardiovascular disease? And one thing I'd like to stress upon, it's a multitude of reasons. One is awareness is lacking. This has been looked at time and time again from the American Heart Association. They actually looked at a study in 2012. It was a study that was actually off of a survey where they surveyed about 2,500 women above the age of 25 between 1990 to 2012. And although awareness among the study population doubled from the beginning of the study from 30% to the end of the study to 56%, it was still extremely low in the population of underserved minorities, such as Blacks and Hispanics. So this we could actually see very nicely here in graphic form. From 1997, whites in blue, Blacks in red, and then Hispanics in green. And we see that there was a steady increase in Caucasian women understanding their risk for cardiovascular disease. However, we did not see that same steady increase in minorities. And this has been highlighted also most recently in the Women's Health Alliance, where they did a survey, which we know that the vast majority of people do not understand that heart disease is their number one risk, particularly if they are a female. But it's not just the patients, it's also us as clinicians. So when in the survey, which was actually released in the Journal of the American College of Cardiology in 2017, only 39% of primary care physicians made heart disease their top priority. Additionally, only 22% of primary care physicians and 42% of cardiologists actually felt well prepared to assess a cardiovascular disease risk in our patients. These are cardiologists alike. So this tells us that education is so important, and CMEs like this are so important for you to feel that comfort and making sure you're managing the patient correctly. And one reason this may be is because, unfortunately, as clinicians, we're still treating patients, particularly female patients, with bikini medicine. So there's this term which is called the bikini approach. It was a term coined by Dr. Nanette Wenger, who has played a very pivotal role in the development of women heart-focused centers as well as programs. And what she talks about with the bikini medicine approach is that essentially we're focusing on the boobs and tubes, as we like to say, so the breast and reproductive organs, and thinking that only reproductive health for women is important, and really ignoring the rest of the women as part of women's health. And this actually has been shown as well in surveys when they surveyed a series of primary care physicians in the community, asking them, well, what is the level of concern in terms of your top health issues among PCPs for your patients, your female patients? And when you look at it, the top two are weight and breast health or breast cancer. The third being heart disease, which we know the top should be heart disease because that is our patient's number one threat at the end of the day. Other reasons why we're seeing an increase in the number of deaths of cardiovascular disease in young women have to do with the lack of awareness of gender-specific risk factors. So we know as clinicians, very commonly, the traditional risk factors for heart disease, the diabetes, the smoking, the obesity, the physical inactivity, the hypertension, the hyperlipidemia, also, of course, family history. It's these risk factors, these traditional that I've listed, that actually make heart disease 80% of the time modifiable. Because if we make sure that those are optimal, our patients hopefully shouldn't have heart disease unless they have their risk in terms of family history. However, we also have emerging non-traditional risk factors that we really, as clinicians, need to be aware of to figure out what our patient's overall risk of having a cardiac event may be. These include preterm delivery before the gestational age of 37. We also know that hypertensive disorders of pregnancy, any type of hypertensive disorder, including preeclampsia or eclampsia, is a risk factor for cardiovascular disease. Gestational diabetes, any autoimmune conditions like lupus or rheumatoid arthritis. Any breast cancer treatments that the patient may have underwent. Many of the chemotherapeutic agents are cardiotoxic, as well as radiation therapy. We also know that depression disproportionately affects more women than men, and it increases one's risk of cardiovascular disease. Further non-traditional risk factors that are not listed include early menopause before the age of 45 or early menses before the age of 12. We also know that polycystic ovarian syndrome is another condition that disproportionately places one at a higher risk for cardiovascular disease by putting them at higher risk of having diabetes or elevated blood pressure. So understanding these emerging risk factors is so important and pivotal for us as clinicians to make sure that we're managing our patients accordingly. Similarly, this is giving an overview of really what we're going to be honing in on today, which is the mechanism of heart disease in women is so broad. It could range anywhere from a plaque disruption to vasospasm to dissection to microvascular disease. And all of this we're going to be focusing in on, but we have to understand that the spectrum is so broad, particularly for women as compared to our male counterparts. And with that, the way to diagnose it is also broad. And this graph is very, very busy. This is actually from a study that I actually did with two other wonderful women in the field of cardiology, where we thought about an easy way to resurface the ischemia diagram. We're starting with even the tiniest of microvessels, the microvascular. What is the best approach in diagnosing it? Should we be using PET? Should we be using stress? Should we be using CAT? Cath, should we be using CT? The fact of the matter is it's very complex. And that's why having an understanding with education, but also understanding that there are specialists out there who can make this a little bit more simple for you is so important. Which then leads me to the next reason why we're seeing this rise in young women, which is there's lack of awareness that women should be used for research studies as well. This is obviously a comic strip here, but it's unfortunately the truth. It's not as funny, but we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody. And that's really something that we as clinicians have to understand. Asking our female patients to join research studies specific to cardiovascular disease is important. So important that actually our large organizations that focus on national research, like the NIH in the 1990s, so way back in the 90s even, they mandated that we have to make sure that those patients enrolled reflect the makeup of the population. Even in the 1990s, the Office of Women's Health was established within the FDA. And with that, in 2007, they actually had a very large meeting, which included academia, clinicians, agencies, and industry, and said, we have to develop a strategy for improving representation of women in cardiovascular clinical trials, because we need to ensure that our patients that are enrolled reflect the makeup of the population. Despite this, however, when we actually look at the numbers, and these are randomized control trials, we see that only 20 to 30% of the time women are included in these trials. And again, our goal is to make it 50% women, 50% men. And this is data most recently in 2020. And one thing that I'd like to stress is with participation of women in cardiovascular trials, we disproportionately place them in trials focused on atrial fibrillation, hypertension, and probably extremely disproportionately in pulmonary hypertension, and trials where we really want them to be enrolled, they're lacking. So acute coronary syndrome, coronary artery syndromes, and heart failure, we're seeing that they are not really being enrolled as aggressively as we would like. And one reason, even though it's necessary to include them, the limitations are there because a lot of the research principal investigators say, well, we at baseline have a low referral rate for women to advanced subspecialties focused on heart disease or even congestive heart failure. So we're just following the status quo. But that's not an excuse, right? Because we know by doing that, the treatment, there will remain treatment disparities for guideline-directed medicines as well as device utilization for all spectrums of heart disease, including coronary heart disease, particularly for our young women between the ages of 35 to 54, peripheral arterial disease, atrial fibrillation, valvular heart disease, and congestive heart failure alike. So we obviously have to be more attuned and make sure that we offer our female patients inclusion into these trials. And because of the fact that we're not including them into the trials, they're not receiving their guideline-directed medications and devices, they, of course, will have worse outcomes, which we're going to be talking about. So how can we change this? Of course, we want to have an integrated, multifaceted approach to promote effective primordial, primary, and secondary prevention strategies among at-risk women. We also want to keep sex and gender role differences in mind when caring for our female patients. We want to, of course, think about research and get funding for research that will move it beyond simple inclusion in clinical trials. but also focus on clinical trials that we already have in our established institutions and make sure that the enrollment in women are just as equal, if not more, than the enrollment in men. We want to also expand initiatives with the American Heart Association and Women Heart to really increase awareness from a marketing perspective. And we want to engage with Women Heart Health Centers of Excellence, like one we have here at Dignity Health. And of course, we want to promote education, like these wonderful CMEs that you have the opportunity to join in today. So with that, really brief background, I think this is where the heart and soul of the talk will start, which is let's talk about the spectrum and the different pathophysiology of cardiovascular disease in women. And one thing I want to stress is that I talked about the different risks, right? There are gender-specific risks. We also know that there are different cardiovascular benefits when it comes to women. We also know that because of that, women have different drug pharmacokinetics. For the most part, they have smaller body surface areas, and with that, they may have more side effects to medications. We also understand when we're focusing primarily on acute coronary syndrome, women after a procedure may have a higher rate of a bleeding complication. It's for that reason, just using coronary angiography as an example, the majority of providers right now are focusing on really trying to avoid the use of the groin, but use the radial approach, because the radial approach tends to lower a female's risk of bleeding. Although we do, when we compare women to men, from a radial approach, they still have higher rates of bleeding compared to their male counterpart, but the radial approach is a better vascular bed to access as compared to the femoral artery and the groin. And we also know that women are very different than men in the mechanism of angina and acute myocardial infarction. And because of that, the diagnosis is often missed until they're in their advanced state of their disease. So because of that, they're less likely to receive guideline-based therapy, and they have worse outcomes. Now, one thing that I'd like, again, another history lesson, as you can see, I love history, is to talk about something called Yentl syndrome. So Yentl, which hopefully many of you know, was the heroine of a 19th century short story by Isaac Bashevis Singer. She had to disguise herself as a man to study the Talmud, and being just like a man has historically been a price women had to pay for equality. And it really wasn't until the 1990s that a cardiologist named Bernadine Healy noted these discrepancies in not just the inclusion in women in research pertaining to cardiovascular disease, but also the treatment of women. And for decades with this, women were deemed to be second class, or treated as second class, or they, in the medical field, were assumed to be little men, which we know, of course, women are not. And with that, it really has made it very hard, I think, and tasking for clinicians to understand the differences of cardiovascular disease in women, even from a symptom perspective. So are we as clinicians continuously suffering from Yentl syndrome? Well, we are. So when we think about sex differences in symptoms in relation to ischemic heart disease or coronary artery disease, we know the vast majority of women, when they are presenting with a heart attack, do present with that feeling like an elephant or a ton of bricks or at the center of their chest. However, we also know that a third of the time, they may have these more subtle or atypical symptoms where they're having back pain or neck pain or jaw pain. They may feel shortness of breath. They may feel very extremely fatigued. They may break out into a cold sweat. They may feel nauseous or even dizzy. And again, the vast majority of the time, we know women are more likely to experience these atypical, as we call it, symptoms when compared to their male counterpart. This has been shown in multiple studies. This was even back in the 1990s, where when you looked at symptoms more common in women compared to more common in men, we see, again, chest pain is really the focus in when one's presenting with acute myocardial infarction for men, but more of that back pain, jaw pain, nausea, neck, and shortness of breath occurs more with women. And with that, we have several studies that have shown that a prodrome of fatigue and even sleep disturbance and dyspnea are again more commonly seen in our female counterparts, where only chest pain, for the most part, when we think about women, chest pain was absent in about 43% of the population looked at in this study. And what this translates into is we know that those who don't present with chest pain tend to do worse because they're less likely to be thought of having a cardiac event. I mean, it makes pretty much common sense. But when we actually look at the numbers, we see women without chest pain had higher mortality rates compared to women with chest pain, as well as men with chest pain. So we really need, as clinicians, to have a very high suspicion that a cardiac event is ongoing based on their risks, but we also need to understand the different types of symptoms that we have to be thinking about. That maybe that indigestion that we thought was reflux is actually not reflux, but maybe it's actually heart disease. So really understanding these differences. And the reason why women may have these more subtle symptoms is because, in all honesty, ACS in women, there's so much more to think about compared to our male counterparts. Again, less common ACS etiologies preferentially affect women, and we're going to delve into what these less preferential ACS etiologies are. So to begin, I think that this graphic here describes really what I'm trying to kind of to demonstrate to you all today very nicely. So I talk about inconvenient angiographic truth because I'm not an interventional cardiologist. I'm very proud that I'm not. I'm a non-invasive cardiologist that focuses on prevention and women's heart health. But of course, I rely on my interventional counterparts. And I can tell you that when my interventional cardiologist sees this picture depicted here, which this picture is really, in all honesty, more of a male pattern, which occurs 3 times more likely in men with obstructive disease, they love to see that, right? Particularly if someone comes in with chest pain, because that's easy for them to fix. All they have to do is take a balloon, open it up, and put a stent in. But the fact of the matter is that women are 2 to 3 times more likely to have not this pattern, where there's not that clear-cut blockage. So no or non-obstructive disease, despite having angina. And that's a term called INOCA, which is ischemia with non-obstructive coronary arteries, or MINOCA, which is an MI with non-obstructive coronary arteries. And I'm going to delve into more of what the spectrum of MINOCA is, because MINOCA and INOCA kind of go hand in hand. But what we may be seeing in women with non-obstructive heart disease is actually it's their microvascular, which again is the female pattern that is causing these symptoms. That's the culprit. And this is something we cannot see on angiography. So a lot of times it makes it very hard and challenging for us as clinicians to manage. With that, we know that women who have chronic persistent angina without obstructive heart disease have a worse prognosis with increased adverse event rates. They have poor quality of life. They have repeat hospitalizations. They have repeat coronary angiographies, and it does consume a large portion of our healthcare resources compared to those without angina. And this actually was just, demonstrated very nicely in a study in 2015, where we see that women, which were in blue, men in purple, the vast majority had evidence of no significant coronary artery disease. But despite not having any significant coronary artery disease, the vast majority had changes in their EKG that were depicting ischemia. They also had higher rates of cardiovascular death, as well as, for the most part, a worse overall prognosis. And when we actually look at the actual numbers, we see that MINOCA has a higher mortality than the general population, up to 5% one-year mortality. I mean, that's a pretty large mortality. Of course, it's not as high as obstructive disease, which is about 6.7%, but that is definitely a high mortality for a disease and condition that not many people are too familiar with. And I'm hoping by the end of today, you understand what the different spectrums of MINOCA may be. And this is really the slide that leads us into them. So when we think about MINOCA, which again is myocardial infarction with non-obstructive coronary arteries, or MI, with non-obstructive coronary arteries. So the way we define it is you have to have an angiogram. And if the angiogram shows less than a 50% lesion, however, the patient had data to suggest they had a heart attack with an EKG and troponins or other cardiobiomarkers, then by definition, they have MINOCA. There wasn't an obstructive lesion, it was a non-obstructive lesion. So then we, as clinicians, have to think of, well, what possibly led to this MINOCA? And that's where really collaborating with a women's heart specialist comes into play. So is it because the patient had coronary plaque rupture? We'll talk about a little more about coronary plaque rupture in the next slide, as well as erosion. but could it also be because of spontaneous coronary artery dissection, which we'll be talking about as well? Now, Takotsubo, or stress-induced cardiomyopathy, is a very common form of Minoka where you have a stressful event that leads to a surge of catecholamines that puts a strain on the heart and really has the heart mimic a heart attack, where the patient presents with chest pain. They present with elevated cardiac biomarkers such as troponins. They have EKG changes, and they have wall motion abnormality that really looks like your apex is ballooning out like an octopus, and that's why it's called Takotsubo, which is an octopus net. The treatment for Takotsubo cardiomyopathy is to try to remove that stressor from your life. We also know that there's evidence to date that have shown the utilization of beta blockers because of that to reduce that catecholamine surge has been beneficial. And if a patient does have a low ejection fraction with an EF less than what is normal, we should also be offering them an ACE inhibitor. So an ejection fraction less than 50-55%. We should also be considering an ACE inhibitor as well to their management of the Takotsubo. Is the Minoka from a type 2 myocardial infarction? So that we know is more of a supply-demand mismatch where perhaps the patient had an infection, anemia, any other, or a hypertensive emergency, for example, or any other type of condition that may have led to a supply-demand mismatch. Could it be that there is a vasospasm that's going on? And this is something that we can sometimes do testing in the lab, depending on which lab you are affiliated with or which hospital you're affiliated with, to test for this. But the treatment is very, very different than it would be for the treatment of someone who had an acute plaque rupture, right? We probably in this, for instance, wouldn't offer these patients antiplatelet agents, but we would offer them something to dilate their artery, such as a calcium channel blocker or a nitrate, for example. Could it possibly be that the Minoka was from an intracoronary thromboembolism? So we want to have a high suspicion and see, does the patient have some sort of hypercoagulable state? Should a hypercoagulable workup be sent out? And that's really where a good history comes into play. Or is it possible that the patient has myocarditis, right? Did they have any a viral prodrome prior to presenting with the symptoms of chest pain, abnormal EKG, positive cardiac biomarkers? Or is it possible that it's microvascular disease? And we're going to be focusing very much on microvascular disease in the next upcoming slides. So I wanted to bring this to the attention of you all about the difference between plaque rupture and plaque erosion, because this is very pivotal. When we think about plaque rupture, we know that that is one of what we thought in the past to be one of the more common causes of an acute coronary event in both men and women. The fact, however, we know is that plaque rupture, where you have a plaque that has been stable and at some point it becomes unstable and bursts, and then that's when all of our factors and such come to it and create a blockage in the artery of the wall. We know that plaque rupture tends to disproportionately affect men and older women. Younger women, however, tend to have plaque erosion, where instead of that plaque rupturing, the plaque actually within itself starts to erode. And this can cause a heart attack. And the treatment for it is very similar to the treatment it would be for a plaque rupture, in that we would provide antiplatelets, statins, plus minus a beta blocker, depending on their risk. The issue with plaque erosion is it's sometimes very hard for us and our interventionalists to diagnose, because you may need additional imaging in the cath lab. Luckily now we have advanced imaging in the cath lab, like intracoronary imaging, that helps this. So really focusing in on the different types, you want to have a high clinical suspicion. I wanted to just talk about pregnancy-associated MI, because I think it's actually a very important topic, and it ties very nicely into another type of Minoka, which is SCAD, or spontaneous coronary artery dissection. We know that pregnancy-associated MIs are extraordinarily rare, in about 6 in 100,000 female patients. We also know that because it's rarity, its mortality is very high, because unfortunately, we don't tend to diagnose it as early as we would like to. We also know that conventional cardiovascular risks are very common in these groups that tend to have myocardial infarction. That includes having hypertension, being a former smoker, even a smoker, unfortunately, during pregnancy. We also know that diabetes, infections, and preeclampsia are common in this group, as well as we know that usually Black women tend to have higher rates of pregnancy-associated MI when compared to other ethnicities or races. And we know that the vast majority of the myocardial infarctions that occur during pregnancy are from SCAD, which is spontaneous coronary artery dissection, as opposed to atherosclerosis or clots. So when we think about, we're going to get into SCAD, but when we think about the timing of pregnancy, we know that when patients are presenting with STEMIs, a large majority actually occur, even NSTEMIs, the vast majority occur in the postpartum period. And that's why we as cardiologists who focus on women's health like to talk about the fourth trimester, where if you had a patient who had hypertension during their pregnancy or preeclampsia during their pregnancy, you want to make sure that you're monitoring them very closely. You may even want to consider sending them to a cardiologist, because that cardiologist is going to be very key on the fact of, one, not just educating them on their potential risk, but also thinking about the subtle symptoms that they may be experiencing, such as the fatigue or the shortness of breath, that may be a sign that they're in imminent danger of having an acute coronary event, and ways of perhaps our ability to prevent that. Now, we know that the reason pregnancy does increase one's risk of a heart attack is because the physiological changes that occur during pregnancy are vast, right? We know that we have increased blood volume, cardiac output, stroke volume, and heart rate go up. Your systemic vascular resistance in the second trimester goes down. With that, your blood pressure goes down. These patients become so much more hypercoagulable. They may have evidence of insulin resistance, and of course, our immune system during pregnancy also can be affected in terms of inflammation. We know heart disease is an inflammatory process. Now, one thing that leading up from our pregnancy related conditions, I said that the vast majority of heart attacks that occur during pregnancy are due to a condition called SCAD. SCAD is spontaneous coronary artery dissection. What happens there is you have, of course, the three linings of an artery, and one of the linings, there's a tear that forms spontaneously, hence the term spontaneous coronary artery dissection. What happens is that blood gets into that dissection flap, and it causes the lumen of the artery to become smaller and smaller, causing decreased blood flow to the heart muscle, which then leads to a heart attack. I want to emphasize that it is not atherosclerosis, and on average, the average age is very young, so in the 40s, and these women tend to have few or no cardiovascular risk factors. I'm going to talk about what are some common risk factors for SCAD, but the vast majority of our traditional cardiovascular risk factors are not associated with SCAD. 80% of women, again, the vast majority of people that experience SCAD are women, and 10 to 20% of the time it is in that peripartum period. So it's very difficult to diagnose SCAD. So we, as clinicians, really have to have a very high index of suspicion. We also need to make sure that we're working closely with our interventional cardiologist, because the way to diagnose it is actually, the only way to diagnose it is with coronary angiography. We can use sometimes CT, coronary CT, if that's utilized at your facilities. However, the better way of really looking at it is with coronary angiography. And even with coronary angiography, it may be missed because we may miss that dissection flap. So you really need to have a high index of suspicion. You also perhaps need to have the use of other imaging modalities in the cath lab. So I mentioned intracoronary imaging. So for examples of intracoronary imaging are an ultrasound that we use in the cath lab, where we're able to look at the lining of the blood vessels. And we also have some other advanced materials, which this is actually an example. So those two intracoronary imaging that we have here within our Dignity system, and the vast majority of our cath labs, are IVUS, which is intravascular ultrasound, and OCT, which is optical coherence tomography. And what you can see is, if this is the lumen of the artery, all of this is your hematoma or your blood clot. This would have been missed, or it could have been missed with just a simple visualization on an angiogram. And even this could have been missed because this is a much smaller hematoma that we're seeing. And we know that in these SCAD situations, as it stands, the majority of people state that if we have very good flow distally from the dissection, we should not stent it. Because what can happen if you try to stent it? Well, this actually is described very nicely here. This patient presented with chest discomfort, abnormal EKG, positive cardiac biomarkers. Basically, they presented with a STEMI. It was then found visually that they have a dissection, and it was attempted to balloon it. And this here, you can see this is the balloon. And with that, what happened? That dissection flap extended upwards, further upwards, all the way to the left main. And unfortunately, this person required a full stent from all the way from their left main all the way down to their LAD. So the vast majority of specialists, and I happen to be a specialist in SCAD, and there's very few of us in the state of Arizona, but even nationally, the vast majority of us specialists tend to say if there's good flow distally, we need to treat them medically with a baby aspirin plus minus Plavix, usually for the first few months or so, a beta blocker. And for the majority of patients, if there's no other evidence of plaque in any other vessels, or if there's no evidence of plaque in any other vessels, we actually should defer using a statin, because some trials have shown that statins can increase the recurrence rate. And it leads us to then say, well, how else should we be treating SCAD patients? Well, we should be treating SCAD patients easy enough by figuring out what is the possible cause for SCAD. And one thing we know is that SCAD commonly can occur in patients that have fibromuscular dysplasia or any other collagen or genetic defect. So we actually screen these patients for fibromuscular dysplasia by doing CAT scans of their necks, as well as their arteries and their kidneys. You can do ultrasounds as well to save radiation from our patients, because the vast majority of them are still in childbearing years. We also know that it occurs during hormonal changes, right? We said 10 to 20% of the time it occurs during pregnancy, but even other hormonal changes, so perimenopause, for example. So you really want to have, or if someone's using infertility treatment or hormonal therapy, so you really want to have a high clinical suspicion. And in other situations, we know extreme sports can lead to this as well. So weightlifters, for example, bodybuilders. So we really want to have a very high clinical suspicion. Now, another type of MNOCA is endothelial dysfunction. And with endothelial dysfunction, we know that instead of our arteries having the ability to constrict, dilate as well as we would like to, they do not. And the vast majority of endothelial issues occur because of our common risk factors for cardiovascular disease. So high blood pressure, smoking, hyperlipidemia, diabetes. We also know that menopause can exacerbate it. And when we think about the treatment of endothelial dysfunction, we know that if we treat these risk factors, they tend to treat the endothelial dysfunction. Now, one type of endothelial dysfunction is microvascular disease. And when we think about microvascular disease, we know that instead of the large epicardial arteries being affected, it's the little tiny arteries that are being affected at the end of the day. And it does affect 2 to 3 million women. Again, coronary angiography cannot diagnose it, and we tend to really hone in on different multimodality imaging. So MRI, for example, stress MRI, even the use of PET and PET CT may help us with this diagnosis. As I showed to you, when we think about women in heart disease, particularly acute coronary events or even chest pain, it's a spectrum. It's a very large spectrum. And we want to make sure with that spectrum that we're managing our patients accordingly. Now, one thing that I did discuss is that if we treat the risk factors, it typically treats the endothelial dysfunction. So uses of ACE inhibitors or statins or low-dose aspirin are key ways of doing that. And as I said, the spectrum of diagnosing it is very vast. It may be anywhere from stress MRI, an echo, a cath. But again, this complexity really tells you that, well, perhaps a specialist is warranted. Perhaps I should refer them to a cardiologist to see if the chest pain, even though their catheterization was normal, is not coming from something else. Now, this brings me to really a very famous depiction that, at least in medical school, I thought of is, or what I was taught was that really for the most part in the past, we thought that in order for you to start to have symptoms or have an abnormal test, you had to have an obstructive lesion or plaque. And we know that that's actually not the case. We actually know that you could have normal arteries, but again, your microvasculature could have issues. And it could be that microvascular dysfunction where, again, we don't see it on anatomical imaging, like a coronary angiography, but maybe we need other imaging modalities to really focus in on it. And it really changes our philosophy that, again, non-obstructive disease is not always false positive. It's not always benign. And really thinking about, again, INOCA or MINOCA in that differential. Now, we really only got to the tipping point, really, or the iceberg when we talk about acute coronary events. And one thing I want to stress is that we also have conditions where we may have a plaque, but our artery naturally dilates to accommodate that plaque. So it's something called expansive remodeling. And this, I think, because a picture is worth 1,000 words, is better demonstrated if I show you an angiogram. So here we have a coronary angiogram where to anybody's eye, there's not a discrete blockage, right? However, if we were to use intravascular ultrasound, which again is an echo that goes into the artery, we see that there's a plaque, a very significant plaque there. And perhaps somebody who would have been told that they don't have heart disease, they actually do have heart disease. And we know that this patient should be treated aggressively with an aspirin, a cholesterol lowering medication to make sure their LDL is at goal. And one thing that this cartoon depicts very nicely is that we know that the vast majority of the time, heart disease in women, younger women, is really more diffuse. And that's why it's very challenging when we're doing any angiograms in patients presenting with acute coronary syndrome. We may miss it because it is very diffuse, and it's more older women or men that have that more common obstructive lesion, as I emphasized. And this is just a case or an example of a 51-year-old female who has a history of obesity, hypertension, and high cholesterol. She had a stent placed to her circ 2 years ago, so she's clearly high risk, and she presents with chest pain. She was ruled out. She has a stress test done, and it was abnormal. So with that, they decided to send her for cath. And if you look at her arteries, again, there's really nothing discrete that we can see. But if we were to use that ultrasound, you can see actually there is a fair amount of plaque there. And if we looked at the same patient and we did a CAT scan on her, you can actually see it much more clearer, that there's a clear evidence of plaque, that plaque being the darker location and the brightness being the lumen, that's causing decreased blood flow. And that's probably why her stress test was abnormal. So in situations like this, we would work with our interventional cardiologist to decide, well, should we stent that patient or should we just aggressively treat them with lowering their cholesterol, putting them on a beta blocker, treating their aspirin. So using different types of imaging has really gone a long way in the diagnosis and management of women with heart disease. Now, let's talk about the guidelines that we currently have. So how are we doing in terms of treating women and men? Are we treating them similarly? And the fact of the matter is that we know that the vast majority of people to date that are having higher rates of death and mortality and comorbidities from heart disease, again, are young women. This has been shown most recently in the RX study that was released in JACC. And we know that with that, they are less likely to undergo invasive angiography, unfortunately. So this graph depicts it very nicely here. Not only are these young women less likely to undergo invasive strategies, they're also less likely to be given guideline-based medications such as aspirin, lipid medications, beta blockers, for example. We also know that in the Get With the Guidelines, which has every year is typically released by the American Heart Association, when you compare women to men, the only thing women did better than men with is unfortunately die. And that's specifically to STEMI. And that's because they were less likely to meet door to balloon time. They were less likely to be referred to the cath lab. They were less likely to be given aspirin and a beta blocker in the first 24 hours after presenting with an acute coronary event. And this has been depicted as well. When we look at a woman compared to men, we see that there's an 8-minute longer lag in getting to the cath lab. And when we think about heart disease, we all can probably agree that muscle is time, right? So we need to get them to the cath lab as soon as possible. And you can see that women directly going to the emergency room had an 8-minute longer delay in getting to the cath lab. And if they were transferred, that delay was 30 minutes longer. And it's specifically for young women less than 55 years of age. And with that, we see that in hospital mortality rates following STEMI among women and men are abundant. And we see that women obviously have higher overall rates. They have more complications really throughout all age groups, including cardiogenic shock, heart failure, renal failure, stroke, reinfarction, or bleeding. And although the increased mortality in women in the past has been attributed to advanced age and comorbidities, we know overall young women with acute MI have a very, very poor prognosis. So much so that the younger the age of the patient, the higher the risk of death among women relative to men. And this has been depicted very nicely in this graph here. So why perhaps is this the case? Well, when we think about what happens on the discharge of the patients, we know post ACS, women are less likely to be discharged on a baby aspirin, an ACE inhibitor, a statin. They're also less likely to meet their blood pressure goals. They're also less likely to be referred to cardiac rehab. I can't stress enough the importance of cardiac rehab. We have a wonderful program here at Dignity Health, and I send nearly all of my patients to, because patients that have mortality or recently had a PCI, a CABG, cardiac valve surgery, patients with heart failure, we know that they actually have a mortality benefit. And when we see that most of the time men are a third more likely to be enrolled in cardiac rehab, we also know that when women are referred, they're more likely to drop out. With that, with the lack of really receiving the necessary medications as well as referral to cardiac rehab, we see that women tend to have a higher rehospitalization rate after they have an acute coronary event, really throughout all age groups, but it is much higher in the younger women, less than 55 years of age. So how can we improve this? And this is really the last steps of what our conversation today is going to be. And one thing is that recently in the Journal of American Heart Association, they had reached out to really think about how can we improve outcomes in women with acute coronary syndrome. And one thing was to increase awareness and need for timely care targeting women. So reaching out to EMS, who's bringing the female patient over. We also want to increase, of course, awareness to healthcare providers. Those are the clinicians like yourself out there, to have you think more about the subtle risks, the subtle symptoms, I should say, and the more gender-specific risk factors to maybe increase your suspicion that this is an acute coronary event or a form of CAD. We also want to implement standardized protocols, perhaps utilize artificial intelligence and increase research to understand sex disparities when it comes to these acute coronary events. One thing that a lot of institutions are working on is using sex-specific thresholds, particularly for the use of troponin, for example. And I think in the interest of time, this is very detailed, but overall, utilizing a high sensitivity troponin, which is a cardiac biomarker, is beneficial because we then can use a different threshold for our female patients over our male patients. And what we actually see with that is, just going to this last slide, is that with using these sex-specific thresholds, we're more likely to diagnose somebody with an acute coronary event. Thus, we're more likely to refer them for angiography, and we're more likely to provide them with preventive therapies. So it's been actually really exceptional. And overall, my hope for today is that you realize that heart disease in women, particularly acute coronary syndrome, there's a large spectrum. We have to think about those non-obstructive conditions that really place a female at a higher risk, because for the vast majority of the time in the past, we would think if there's not an obstructive lesion, they don't have heart disease, but maybe they do. Maybe they have a different form of it. We also, I hope, through this, you understand that our younger women are the ones that are at really the greatest risk at this point in time. And we have to think about these different types of etiologies or pathophysiologies for heart disease. We also have to think about the different risk factor profile, again, to have you as a clinician have a very really heightened suspicion. And just to kind of end it off, one thing that helps this, again, is really having an affiliation with a center that has a women's heart health program that really wants to focus in on the clinical aspects, the research, the community partnership, and the education, and really provide you with that understanding that you have someone here to kind of support any questions you may have and make sure that you're managing your patients accordingly and well. So with that, I'm going to now hand it over to Susan, because I'm hoping that we have a few questions from our talk today. And I'd be more than happy to answer any or all of the questions. We can actually see if a few of them have popped up already. So one question we have is, what are some early symptoms you would want both women and men to be most aware of? So I think we highlighted this very nicely in the talk earlier, but when we think about heart disease, we want to not just focus on the common chest discomfort, that sort of elephant sitting at the center of your chest, which we think more commonly when someone presents with a heart condition or a heart attack, for example. We want to think of the more subtle symptoms like, oh, I'm feeling very tired, even though I'm getting my proper amount of sleep. I'm just so exhausted, I'm tired. And even if your workup for, ruling out iron deficiency anemia or any other cause of what chronic fatigue may be comes back normal, well, maybe it's the heart. You want to also think about that indigestion, that area. Well, maybe it's not the stomach, maybe it's the heart, particularly if that person has several other risk factors for heart disease, including a very, very strong family history, or even back discomfort, neck or jaw pain. So those are really the more subtle symptoms and usually the more early symptoms when we think about a heart attack. I can't tell you enough how many women said to me the weeks leading up to my heart attack, I just felt exhausted. So we don't want to ignore that statement in our female patients. If they're exhausted, and they usually are not, we really want to have them think about, as well as yourself think about, the possibility of this being their heart.
Okay, well, we're at the 1 o'clock hour. We've taken your time. I want to thank everyone for joining us today. That wraps us up. We'll let you get back to seeing patients. We hope you all join us next month on February 20th for the second CME in the series, Prevention in a Nutshell with a Twist on Women's Heart Health. Please make sure that you receive the instruction email within the next hour. If not, you can text me or call at 928-699-4797 or email me at susan.bray, and that's B for boy, R-A-Y, @dignityhealth.org. I'll also keep the WebEx on for a few minutes so that we can catch any calls, questions, or anything that we have concerns about. Thank you so much for joining us, and this ends our WebEx for the day.